Thanks, guys, for coming along. In the interest of time, we might get started. So before we begin, I'd just like to acknowledge the traditional owners of the land on which we meet today, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past, present, and emerging. On behalf of the Australian Student Society of Haematology, I'd like to welcome you all to the 4th ASSH Seminar titled Approach to Blood Cancers. Each year, over 65,000 life years are lost to blood cancer. As medical students, we often learn about blood cancers rather tangentially. And suffice it to say, the 1 or 2 lectures that we receive on blood cancers in 1st and 2nd year medicine does not do justice to the hugely fascinating world of haematological malignancies, the treatment of which has seen a seismic shift over the recent decade, with novel agents getting pushed onto the market at an unprecedented rate. What exactly is the difference between leukemia and lymphoma? What distinguishes the many, many different types of lymphomas and leukemias? And how has the treatment of hematological malignancies changed in recent times? And what are some of the emerging therapies in this space? To answer these questions and more, it gives me great pleasure to introduce you to Associate Professor Andrew Wei. Associate Professor Andrew Wei is a haematologist and Medical Research Future Fund Fellow at the Alfred Hospital in Melbourne, Australia, where he conducts clinical and translational acute myeloid leukemia research in collaboration with Monash University, Melbourne. In particular, his research group focuses on the mechanisms by which cancer cells co-opt and coerce intracellular signaling pathways to promote dysregulated cell survival, proliferation, and growth, with a focus on identifying new therapeutic targets for leukemia. Associate Professor Wei completed his PhD at the Walter and Eliza Hall Institute for Medical Research in Victoria, Australia in 2005, during which he contributed to discoveries on the role of BCL2 and MCL1 in cancer. He later joined Alfred Hospital in 2008, and he is now the head of leukemia research. Since completing his doctoral studies, Associate Professor Wei has been involved in over 50 AML clinical trials, leading many as chief investigator, and has authored over 100 publications in peer-reviewed journals, including first or senior author publications in the Journal of Clinical Oncology, Blood, Leukemia, and Cancer Cell. He has also been the AML Disease Group chairperson for the Australasian Leukaemia and Lymphoma Group since 2009, establishing several national trials and a national AML registry. He is also executive member of the ALLG Scientific Advisory Committee, chair of the Cancer Council Victoria Medical Advisory Committee, and works on the Independent Health Pricing Authority, providing advice to the Australian government. As part of his translational research, Dr. Wei established the Alfred Haematology Tissue Bank, diagnostic molecular hematology laboratory services, and a preclinical research laboratory investigating therapeutic targeting of AML survival pathways at the Alfred Hospital. Would you please join me in welcoming Associate Professor Andrew Wei.
Thanks very much, Victor. And I know that some of you should be at home studying for some exams, so thank you for taking some time out to be here. It's been about 29 years since I've stepped into this building, so I don't think it's changed all that much, but I hear that you're going to get a new building, which I think this faculty very much deserves. So I'm not obviously going to spend time talking to you about the intricacies of blood cancer diagnosis, because that would obviously take many more hours than I have tonight, but I'm going to keep my talk fairly focused and give you more of a flavour of some of the things that I found useful perhaps as a medical trainee, and then talk a little bit about how I got into leukemia research, and then just give you some broad overview as to how I guess becoming a researcher is possible in the medical field, and what does translational research mean, because I can definitely say that when I was at this stage, I had no concept about research, academia, clinical trials, cooperative groups, etc. It was all just about basic things. So sometimes it might actually be quite good to have some insight into these things, because some of you in this room will probably end up in academia and doing trials if that's your fancy. So let's see how this goes. So as Victor mentioned, we don't often think of blood cancers as a high-profile malignant disease, but as you can see here, collectively, the life years lost from blood cancers collectively about third or fourth there. So certainly higher than breast cancer, which no one would have really imagined because breast cancer has such a high profile. And the issue is that many of these more common cancers like melanoma, breast cancer, etc., they don't often kill people. So there are a lot of people diagnosed with breast cancer and melanoma, but surgery fixes most of these conditions. The big difference about blood cancers, and particularly leukemias, is that they are disseminated from diagnosis. And so you can't cut it out. And so really you need chemical therapy to get rid of the disease. And to give you some concept as to how difficult that is, each day, you've probably heard this before, there's 100 billion blood cells being produced every day. And so by the time someone presents with a blood cancer, there are hundreds of millions, if not billions, of leukemic cells there that you have to get rid of every single last cell in order to be successful. And so that's been extremely difficult. So the other thing that might surprise you is you can see here that the number of deaths from acute myeloid leukemia and multiple myeloma in the blue and red curves, there's a steady increase in those two diseases. Compare that with non-Hodgkin lymphoma, which is the grey curve at the right, at the top. You can see there's a big inflection point because of the introduction of a drug which has revolutionized that malignancy. Does anyone know what that drug might target? No. So that's a drug called rituximab, which targets CD20. So it's the first monoclonal antibody developed for non-Hodgkin lymphoma. So the other inflection, as you can see, is that I guess mauve-coloured dashed line towards the bottom. That's CML, and you can see the inflection point in the early 90s when imatinib was developed. So you can see how a couple of novel therapies can really change the course of disease. And I guess in acute myeloid leukemia, the area that I've worked in since 2017 in the United States, there have been 8 new drug approvals when we didn't have any new drugs in AML for the last 30 years. And so the question is, will that red curve inflect and go down over the next 10 years as we make progress in a disease where we've made no progress for many decades? So most of you will know that blood cancers basically conceptually arise from their normal counterparts. So it's not as if some alien ship has landed in your body and set up a new cancer. It's basically your own cells, which are genetically perturbed because of mutations, and reprogramming of your normal cells to grow excessively, to not die as efficiently as it should, to have increased self-renewal capacity. These are all the hallmarks of cancer. And so basically any of these cells can become malignant. So for instance, if your stem cells become leukemic, then you will get acute undifferentiated leukemia because it's an early stem cell. If your myeloid progenitors or your lymphoid progenitors mutate sufficiently, then you'll get AML or ALL. So these are the early leukemias. Contrast this with diseases of later stages of development. So you can see malignancies of platelets gives you a condition called essential thrombocytosis. There's a condition called hypereosinophilic syndrome or chronic eosinophilic leukemia. CML involves a progenitor sort of a bit earlier on than the neutrophil and basophil stage. Chronic myelomonocytic leukemia gives you excessive monocytes. Polycythemia vera is due to proliferation of red cells. And then you've got peripheral T-cell lymphoma, B-cell non-Hodgkin lymphoma, and Hodgkin lymphoma, where we're not exactly sure of what the original counterpart is. So you can see it's all fairly logical, and I prefer to explain it this way than what you generally get taught, which is there's AML and there's CML in terms of acute and chronic. That doesn't tell you anything because it's just looking at the words rather than the origin of the cells. So if you know your cell lineages, you'll know pretty much all the malignant possibilities. So basically, in the genomic revolution at the moment, what we're finding is that most of these diseases, which were originally morphologically classified, are basically all because of mutations. And so if you look at all of these diseases and you try and list what are the etiological mutations, you'll probably find that at least half of them now have been discovered. half of the malignancies still don't have a causative mutation, but they will be identified probably in the next 10 years. So I would say in the next 5 to 10 years, the whole classification of blood cancers will move from a morphological basis to a molecular basis. And so when you guys start practicing, the whole area is going to just change so rapidly. Blood cancers have led the way in so many pioneering research efforts. So for instance, the first stem cell was a leukemic stem cell. The first ever whole genome sequencing was done in a patient with leukemia. The first tyrosine kinase inhibitor developed to a specific targeted therapy was CML. And so blood cancers, because the tissues are so readily extracted from the body, you can extract it multiple times during the course of therapy, and you've got billions of cells to do all kinds of experiments in. Whereas you can't do that with a brain cancer. You just can't go and fish out as much tumor as you want whenever you want. That's why leukemias and blood cancers have been so amenable to research development over many, many years. So I just put this up because I was thinking, you know, what was going through my head when I was in third year, and basically it was how to take a history. And basically your first goal is to pass the clinical exams, and the question is, how do you collect information from a patient in 20 minutes where you're given to take a long case? You still do long cases? Yeah. And basically present it in such a way that your examiner thinks you are more than just the average student. Because most of the times when you're taught in medical school, you basically get taught, take a history, go through all the systems, and then regurgitate it back to the examiner. And when examiners sit there and they hear the 14th long case for the week, the same old method, it's quite tedious. So if you can separate yourself from your peers by taking a problem-based approach and synthesizing the things you collect into your history into an organized manner, you will stand out dramatically. And so one way in which one can collect it is just to divide it like a tic-tac-toe thing on your sheet of paper. And then as you're getting the information from the patient, organize it as you're doing it. Because there's no point collecting everything and then you've got 5 minutes at the end to reorganize it all and then try and come up with the synthesized analysis. It's very difficult. Plus, you won't be collecting information from the patient that's in a way that fits the problem-based approach. So when you go to the patient, you grab their medical chart, you write down all their medications, and you put it into that middle box on the left. That way, you're not missing out on any medications that should give you a clue as to, well, why is that person on, carvedilol, for instance? If you haven't got a history of some cardiac problem, you need to ask the patient again. Now, ask by asking the patient, what do they think is their main problem? Okay, so it's always important to understand what the patient perceives as their main problem versus what you objectively assess as their main problem. So you can say, subjectively, the patient's main problem is this. Objectively, I think the main problem is probably something else. And then it's up to you to decide whether that assessment is accurate or not, and the examiner to decide whether you're on the money or not. And then as you go through your problems, obviously you've got your symptoms, ask the patient what investigations they've had, what you think the differential might be in terms of whether those investigations, anything's missing, what the treatment is, monitoring, and what prognostic things have been done. Because it's showing the examiner that you're synthesizing, for instance, this person's got cardiac failure, these are the symptoms, these investigations, these are markers of severity, the differentials for these symptoms could be this is the patient's treatment, they're monitored with this, and their prognosis is probably this. So then that way, the examiner doesn't really need to ask you about, well, what other investigations would you like to do? Because you've already told them what they want to hear. So rank the problems in order of biggest problem to smallest problem, and then go through each problem. So I saw so-and-so, and his background is this, pertinent elements of the social history. His main problem is this, and go through this list. His second problem is this. His third problem is this. He's also on these other medications for this, this, and this, but they're inactive. And in summary, your summary is now spent trying to synthesize what are the key elements of medical management. Why is this patient in hospital now? Okay, so if you can go half of the way towards doing that, I think you've cracked what it means to be a consultant and to do medicine, because basically this is all we do. Now, the other thing I'll tell you is that if you think about doing your cases like this, then this is how your study should be organized as well. So, for instance, I don't think it's necessarily efficient. You still use Harrison's. Has it been replaced by something else up to date? Yeah. So there's not much point reading Harrison's from cover to cover, because that's not how you use medicine in practice. So I would collect your data in a way that's reflective of what you do on a day-to-day basis. So for instance, if you see 3 or 4 patients in a day, each of those patients will have a medical condition. You should study those medical conditions, because you've got a mental picture of this is Mr. Jones and he had this, and now I'm going to study this disease. So study it in the way that you're going to be examined in your long case and your short case and in your written. So basically you've got the diagnosis. Now, yes, you can read the Harrison's symptoms, but that's not how you examine a patient. When you present a short case, you start with the peripheries, you go up to the head, you do the neck, you do the cardiovascular, etc., etc. So put down your study in that order, because when you're presenting the case, that's how they want you to present it. So think about a patient with, for instance, Huntington's disease or some other systemic condition like myasthenia gravis. Okay, if you collect and write the symptoms down in the order in which you examine it, then you will give a beautiful short case presentation, because you can say on examination, generally the patient looked like this, sort of the droopy eyes. On periphery, there was a weak handshake. Just go through the examination like that. And then you can say the patient didn't have this, didn't have that, because you've already memorized how you would examine it. That's how you should study it. And then when you go through the more details, differential diagnosis, you've got a differential diagnosis for the condition, what investigations you like to do, treatment, complications, monitoring. Exactly the same as how you study it and present it in your long case. Okay, so I don't understand why your study should be any different to what you want to do in your clinical exam. So that's my suggestion as to how to make it relevant, and use multiple sources to fill in the gaps, Harrison's, up to date, whatever you like. But synthesize everything into how you want your clinical exam structured, and these are your notes for life. Okay. Now, rotations. So obviously, when you get into medicine, you're going to have to start choosing some rotations, and you'll be vexed with, I've got 4 choices and, I've got 15 options. Very difficult. And I can't tell you what the right rotations to do are. However, it is sometimes useful to consider doing some rotations which are applicable to all areas of medicine, not just neurosurgery, for instance. Okay, so I can tell you from personal experience that I scored dermatology in my first year, and I thought, oh my God, I never want to do dermatology. But it's a systemic disease. You see skin diseases and manifestations in so many different areas of medicine, and it's a very clinical disease. Okay, if it's all about information, you can read and memorize information. But if it's a clinical specialty and you only can diagnose the condition by looking at it and getting an expert to show you this is a difference between a papule and a nodule and a plaque and a this and that, then that's where those rotations can be really useful, because you cannot learn those from books. Another rotation which is surprisingly useful is anesthetics. Now, many of you would have no desire to be an anaesthetist. However, most of you will be sent to the country as medical registrars. And most of the time you will be faced with people having cardiac arrests and poor airways, and there's not a single anaesthetist on site, and you will be it. Some of you may decide you want to go overseas and do stuff. I can tell you, being able to put in chest drains, intubating people, how to resuscitate people, how to give intravenous drugs confidently, will just make you a better doctor. Because most of you will go through all your medical career and you've never actually drawn up an ampule of adrenaline and injected it into a human being. And that'd be a shame, because you're supposed to be doctors. You're supposed to be able to take control of emergency situations. I've been on aeroplanes where patients have arrested, and suddenly anesthetic training was suddenly really useful, whereas I could be the world's greatest haematologist, but I'd be absolutely useless if someone arrested before me and I hadn't done an anesthetic rotation. Plus being able to put in central lines and those sorts of things, all the things which are scary in ICU, the anaesthetists do it better than anyone. How to cannulate really difficult patients, how to put in an art line, okay? They are just technical things which a monkey could eventually learn, but they do make the difference between you feeling confident as a doctor under a pressure situation than feeling useless and inept, especially when you're the registrar and you're expected to know these things. Now in haematology, I think someone's discussed the central match system.
No, not that.
Okay. So I think more and more specialties are becoming a bit like this. So this is something you should think about towards the, when you've done your physician's, just before you're sitting your physician's exam. Because, and no one ever told me any of this stuff, so it's good that you guys are learning it early. But once you finish your physician's exam, then you need a job, because you're either going into general practice or you want to go into a specialty. And more specialties have these central matching systems. And yes, it is a computer match where you just put in your preferences, and then the hospitals put in their preferences after you have an interview, and then you theoretically get a job, right? I don't think it works like that. So unfortunately, it does pay to go and visit the heads of departments from the major hospitals that you want to get a specialty job in, because at the end of the day, it's very hard to extract everything about you from a CV. A 5-minute conversation, a meeting, they can picture a face, they can hear what you like, get to know you a little bit. It's very difficult when you're sitting in front of 25 consultants trying to tell them why they should hire you into their specialty program. So it just gives you a second opportunity to present a good face about who you are, rather than in that really artificial situation where you may not probably come across the way you normally are, because it's a very artificial situation. So have you heard about these central match things? So I'm pretty sure they do it for oncology. Now it's haematology, and many of the competitive specialties that are all doing this now. So think about that. Now for haematology, you can either decide to do joint training, which is pathology training, as well as clinical training. Has one of the other speakers talked about this? A little bit. So the question is joint training. It's an extra year. You have to do 5 more exams after doing physician's exam. It's probably the longest exam pathway of any specialty. Why the hell would you want to do that? Well, for 1 extra year, first of all, you get a whole new college degree on top of that. So most of people doing medicine will get an FRSEP, and that's a 3-year course. So cardiology, neurology, gastroenterology, they're all College of Physician trainees, training programs, 3 years. Haematology, 4 years if you do this joint training thing, plus you get an FRCPA, which is a College of Pathology qualification. Now, why is this potentially important? I think it's potentially important because more and more specialists in the future will be needed to diagnose and interpret molecular pathology tests, correct? So molecular pathology tests are signed out by pathology departments. If you can be a fellow of the College of Pathologists for that 1 year, even though you're a physician, you can also sign out probably molecular assays. You may have to do some genetic counselling courses, but that could mean, for instance, that you could be a neurologist, and they don't have anything at the moment, but they will in 10 years' time. You could be a neurologist, but then if you had the College of Pathology training as well, you could then sign out all neuropathology molecular tests, for instance. So every specialty will become more and more molecularly based in the future. And I would say a fair proportion of you will probably become genetic counselors, molecular pathologists, or bioinformaticians. Okay. These are the new specialties of the future, and I think you guys have the biggest opportunity of preparing yourselves for that, because a lot of people looking for jobs at the moment don't have that training, and they can't report molecular pathology, even though it's the fastest growing area of medicine at the moment. Artificial intelligence will become a huge product of the future. So those people with bioinformatic training, will become, the really valued physicians of the future. So just think of some of these new things coming through at the moment. Now, I'm going to spend a little bit of time just talking to you about just some broad aspects of acute myeloid leukemia, because that's the area that I'm most involved in, and then move into a little bit about what academic training is all about, because that would be a complete mystery to some of you. So myeloid neoplasms, they're a myeloproliferative disease, there are myelodysplastic syndromes, and there are acute myeloid leukemias. So myeloproliferative diseases, as those diseases acquire more mutations, can then transform into acute myeloid leukemia. And so that would be called a secondary AML. So that's why there's an overlap there, because a proportion of MPDs and MDSs will transform into AML. Therapy-related AML refers to patients who have AML because of prior exposure to chemotherapy or radiotherapy. And that's because both of those modalities increase mutational burden. So you can see everything is based upon mutations. In terms of classification, if you get to this point, you just need to have a look at the WHO classification 2016 for myeloid diseases. That's a full explanation of how it's classified. And the European Leukemia Net 2017 version will give you everything you need to know about AML diagnostics, treatment, prognosis that the whole world uses. So I won't go into those in detail, but those are the key references you need. In terms of guidelines for AML treatment, Australia doesn't really have anything, and most of the world references the NCCN, the National Cancer Network in the United States. So the NCCN website, in fact, has this beautiful document of every cancer, the treatments, the diagnostic pathways, the prognostic elements. So if you want the most up-to-date reference on every cancer, NCCN has everything, and it's all described in beautiful tree diagrams, etc. So it's synthesizing the world's knowledge into one portal. So that's the most efficient way to understand oncology as quickly as possible. Leukemia, you can see there's an increasing number of people getting leukemia. Why do you think that is? So many blood cancers, as I've mentioned before, the etiology is an accumulation of mutations, and accumulation of mutations is a product of cell division and time. So as you get older, you accumulate more mutations. So blood cancers are most frequently occurring in older people. And as a result of the world getting older, that's why leukemic numbers are going up. And so the incidence is increasing in older people, and the patient burden is going to increase, probably double over the next 25 years. So there'll be a lot of people with blood cancers. You can see here the epidemiology. So at the moment, the average age is someone 67 years. So 50% of people are over 67 years of age when they get AML. And the proportion of people over the age of 65 in the world is going to double between now and 2050. So you can see there's going to be a lot of people. Now, this is sort of the picture of AML when I finished my research. So from 1973, when the major treatment regimen for AML was developed, which is called 7 and 3, 7 days of ROC, 3 days of an anthracycline. You can see in the 1970s, the blue curve at the bottom, that was the survival curve of 5 years for the AML population. And the chemotherapy era over 30 years has developed those benefits. So 2005, we're not going to really see more improvements than that, which is a bit sobering because half the population is over the age of 65, as I've just told you, and you can see 5-year survival is under 20%. So when you guys graduate and start practicing, it's going to be your generation where you're going to transform the lives of patients with this disease, and you're going to see survival in those categories rise dramatically, because your era will be the one where you will use the novel drugs for leukemia that are being developed today. So there's been 8 new drug approvals in the last 2 years in the United States. Only one of those drugs has made its way to Australia so far. So that means at least half a dozen will come sweeping through over the next 5 years. And then you'll be the first generation to basically use those new drugs as routine care. So, as I mentioned before, leukemia is essentially a hierarchy of mutations. So you'll get an initiating mutation at some point in your life, a few years later, a second hit, and then a third hit. Have you heard of a person called Don Metcalf? So Don Metcalf worked over the road at the Walter and Eliza Hall Institute, and he developed colony stimulating factors. And he gives a good example as to why there are so many mutations in blood cancer. And that's because there's 100 billion cells which divide every day. And each of those cells has to divide in 20 minutes to make 2 daughter cells. And in 20 minutes, the DNA has to replicate itself. And it's a bit like copying the Encyclopedia Britannica letter for letter perfect in 20 minutes. And the mathematics are such that 1 in 3 cells, there'll be a single nucleotide transcription error. So you've got 100 billion cells every day. 1/3 of those cells will have a nucleotide mutation multiplied by every single day of your life. And so the mathematics of that are such that there will be cells which have 3 or 4 transcription errors in key coding genes which are important for leukemogenesis. And so that accumulation of Darwinian evolution, clonal evolution, is basically the genesis of leukemia. And so if they occur in a progenitor and you get enough mutations in the right or wrong cell, that will now form the basis of blood cancer. So there are some pre-leukemic mutations, which are obviously the initiating lesions, such as DNMT3A, TET2, and then some initiating mutations, which I've listed there. Cooperating mutations, which then accelerates the leukemia by either blocking differentiation or stimulating proliferation and self-renewal. And then you get subclonal lesions, which are responsible for drug resistance. So here you have 1, 2, 3, 4 hits in any combination. So there's many, many different ways of getting leukemia. It's not like CML, where you just have 1 hit, BCR-ABL, and that's the disease. With AML, it's a bit like colon cancer. You need multiple hits to give you the full phenotype. And that's why the genomic landscape is, complicated like this, because many different pathways can lead to the same disease. So this was a major project done by the University of Washington, and they sequenced 200 genomes in leukemia, and they found 237 mutations and 13 mutations per patient. That's not the interesting thing. The interesting thing was they basically said when they presented this at the major conference for the first time, the gene discovery age for AML is over, because it basically sequenced everything. There's nothing more to discover. And in reality, there's not really been any new mutations which have been discovered. So everything we need to know about AML genomics, save smaller discoveries, has already been done. So now, when you practice, the era will be the therapeutic era. So how can we use drugs to target and tackle something as complicated as this? That's going to be the future challenge for the next 25 years. So when you're thinking about targeted therapy, it becomes very complicated because you've got all of these different things and you think, well, what do I target? Because how can you possibly target a patient that's got 5 mutations in a row? Furthermore, it's even more difficult because once you target something, then clonal evolution will be such that something else will evolve that wasn't even detected at diagnosis. So you've got a whole set of new lesions when the patient progresses. And so that's why we're not going to cure leukemia in a short hurry. So in the 1970s, we classified AML based upon morphology. And then in the 1990s, cytogenetics came about. And cytogenetics actually was our first modality for personalized medicine. Because do you know what we use cytogenetics to determine in terms of treatment? So if you're a cardiologist, the end of the line is a bypass graft. If you're a gastroenterologist, the end of the line is a colorectal surgeon to cut it. What's the end of the line treatment for a blood cancer? Stem cell transplant, because we don't have surgeons, because nothing to cut out. So cytogenetics was used to determine who should get an allogeneic transplant, because if our chemotherapy couldn't cure someone, which is the poor or adverse risk group, then we'd do an allograft. If, however, we know that chemotherapy cured a fair proportion of patients with, say, core binding factor cytogenetics, then we didn't need a transplant. And so this was a kind of personalized therapy using cytogenetics to personalize who needs an allograft. The problem was, you can see that big gray area, which comprised over 50% of patients with leukemia, there were no cytogenetic abnormalities which were discriminatory between poor risk and high risk. But this all changed with molecular genetics. So one paper came out in 2008, which identified that FLT3 mutations, the black curve there, suddenly took an average risk patient and identified them as being very poor risk. Now, the 2 drugs that I mentioned before, 7 and 3, we still use those in 2019. And pretty hard to believe that those 2 drugs were discovered back in 1950 and 1963. So daunorubicin, the way it got its name is that there were 2 groups looking for soil antibiotics at that time. So the Italians found this streptomyces organism and called it La Dornomycinia. And the French found the same organism and they called it rubidomycin because it was red color. Funnily enough, they both presented their findings at the same conference and realized it was the same organism they were talking about, which when they looked at the extract was cytotoxic. So they knew it was a chemotherapy derivative. And so they basically had a gentleman's agreement and they fused the name to call it daunorubicin. Aracy was basically discovered off the coastal waters of Florida, where marine biologists were just looking for sponges. Sponges as a source of, again, antibiotics. They found this beautiful blue sponge. And again, they basically boiled it and the extract was cytotoxic. And so from this came Aracy. So these 2 drugs pretty much still form the building blocks of chemotherapy at the moment. The reason this FLT3 discovery was so important is because this poor risk subgroup was the first AML subgroup where we developed targeted therapy towards it, so a FLT3 inhibitor. Now the question was, would a FLT3 inhibitor work on its own in leukemia? Well, no, it didn't. But when we combined it with these 2 drugs, it actually did work. And so that led to the first drug approved in AML for many, many years. So midostaurin is a FLT3 inhibitor. And about 18 months ago, this was listed on the Australian PBS formulary. So when you go into the hospitals, you'll see patients with AML. You will talk to some patients that have got FLT3 mutation, and they're on this drug called midostaurin, because this is now standard of practice in this disease. But let me just tell you that in the United States, other drugs have been approved by the FDA in the last 2 years. So this drug, Mylotarg, which targets CD33, BCL2 inhibitor, a hedgehog inhibitor, an IDH inhibitor, a FLT3 inhibitor for relapse disease, another IDH inhibitor for IDH1, IDH2 inhibitors. So, and this is just the beginning. By the time you guys graduate, there'll probably be another 10 new drugs approved for leukemia, because we just know so much about it. There's almost a drug that targets everything under the sun now, and it's just a matter of waiting for the trials to come through and it'll become an approved therapy. So it's going to go absolutely crazy in the next 10 years. In general, what do we want from drugs? Well, first of all, we want drugs to, and that's why it's always important to come back to first principles, not to try and remember every single drug, but trying to understand what do we want from the drugs. So the first step is we need to get people into remission, because with leukemia, they have a wiped out blood system, no red cells, no white cells, no platelets. They'll either die from infection or bleeding within a few weeks unless we get them in remission and restore normal blood counts. So that's the first goal. So we need remission-inducing therapies. And the second goal is stopping relapse, because although we can get 80% of people into remission, 60% will relapse within the first 2 years. So in the future, what will probably happen is that we'll be measuring clonal minimal residual disease, and we'll be applying what we call maintenance or MRD eliminating therapies to try and prevent this relapse. And then the third category will be patients where they've sort of escaped the dragnet of monitoring and they've relapsed anyway, and now we've got to treat relapse and refractory disease, which is incredibly difficult. No one has cracked that situation at the moment. So in terms of professional development, what have I done? Well, I did the clinical training, I did the 2 years of lab training, and then I was actually set up to go overseas to England and do a fellowship, but then someone approached me and said, oh, do you want to do a PhD? I had no idea what a PhD was at the time, no concept of what research was, but I did decide to do a PhD at the Walter and Eliza Hall Institute. And then when I finished my PhD, most people go on to do postdocs, et cetera, I decided to walk away from the research. And I went back into the hospitals, and I was working at Box Hill and Monash Medical Centre. And then I got another job at St Vincent's, both of them focused on AML. And then I went over to the Alfred after that. So the one thing that I did that I think was different to most other consultants at my level was that I focused. So most of you will do lots of different things. Say you specialize in whatever area, but you're specialized in everything. I decided to gamble and basically said, I'm going to do nothing except AML for the rest of my career. And I think if you want to do academic work, that's what it takes. You have to focus. There's no such thing as someone who's become an academic who does a bit of everything, because the world is just progressing at such a fast rate that you cannot possibly know more than your colleagues, even if you spend 24 hours a day studying it. So basically, all of my clinical work, all of my research work, every single talk I did from 2005 onwards and now is on AML. I think I've done 2 talks in 25 years, which are not got the word AML in it. And the reason that I focused was because when I was doing my consultancy at the time, I had a chat with the person who was the most successful scientist in the building. And I didn't ask him for any advice. He just said, Andrew, if you want the advice for success in academia, you've got to focus and just pick one area and absolutely hammer it for the next 7 years. And if you do that for 7 years, you become the leader in that specialty. That's what he said to me. So that was the only reason I decided to gamble on one disease. Now, the other thing is, if you train as a clinician, how can you be a researcher? Because when we think of researchers, we think of the people sitting at the Walter and Eliza Hall Institute or somewhere similar. And my feeling is the way for you to be successful as clinicians is to think about becoming translational researchers. what is translational research? That is taking biology and finding a human solution for that problem. And the most potent way that you can be academics is to do clinical trials, because you need physicians to do clinical trials. They can't be mouse doctors sitting in a science building. But you can collaborate with those people extremely well, because they will need you to translate their work. And so if you become a physician, whatever specialty you like, my advice is, if you have any interest in academia, learn the art of how to do a clinical trial early. And the problem is, there is no roadmap to doing clinical trials. There's no course to do that. What you can do, however, is apply for a clinical fellowship position in a unit that does clinical trials, and they will teach you how to do clinical trials extremely well. So I've had a clinical fellow position for the last 7 years, and each of the people that have come through are now clinical trial experts. I didn't go through one of those because they didn't exist in my time, so I had to teach everything myself, but all the things that I learned and all the things that I learned that I shouldn't do, I can pass on to people that want to do that. The other thing I did was I joined my cooperative group. So every specialty discipline will have a national cooperative group which is focused on doing trials. Surprisingly, the cooperative group gives you the greatest opportunity to do trials on a national level, and surprisingly, there'll be very few volunteers in your peers that will put up their hand to do those positions, because it takes extreme focus and dedication. And surprisingly, there are very few general medical people that are prepared to focus to that level. So if you're that person that wants to focus for 6 or 7 years in cardiology, neurology, oncology in a specific area, you join your cooperative group, you'll be instantly able to run all the trials for the country in that area, because there'll be maybe only 2 or 3 people in the entire country that would have done the same thing. So there's no magic potion about it. It's not as if someone will hand you the keys to something, but it just takes, I guess, personal decision and then some kind of discipline to just focus and commit yourself to an area until you gradually become the leader in that. And anyone can do that if they commit themselves sufficiently to that, I think. So, so once I decided to do AML in a big way, what did I need to become a translational researcher? Well, first of all, as I said, you had to do clinical trials. So there are 2 types of trials. So there are company-sponsored trials where the companies have a trial and they come to you and they want you to do the trial because you've got the patients. Or you can do an investigator-sponsored trial, which is you develop the trial. And that's actually not as hard as it sounds, because what is a trial? Literally means you write a protocol about how the trial should be run. You get it ethically approved and you raise the funds to run it. And then basically it's your trial. So again, you can learn that through becoming a trial fellow. The other most important thing about academic work is you need to learn how to write grants, because writing a grant and getting grant money is the way you can enable yourself to do research. Because to do research, you need trial coordinators, you need molecular coordinators, you need people to do bench work, because you can't do everything yourself. So you need a team of people to do that for you. You need money to run the trial. The only way you can get money is to write grants. But more than anything, grant writing and grant success will give you the keys to academic recognition. And so I can tell you that if you're applying for a hospital-based position and you have a PhD, you know how to run a trial, you know how to write publications, you know how to write a grant, and actually are successful in running a grant, every single hospital in the country will want to employ you, because those are the things they can't find easily. There are millions of cardiologists and neurologists, et cetera, and the problem is they're going to be harder and harder to squeeze general neurologists into a neurology department, because there's queues of people from every single year waiting for those positions. If you do something different, specialize in molecular genetics, have bioinformatic knowledge, know how to write artificial intelligence programs, or know how to do translational research. If you want to work in a hospital, that is the best way to get the keys to entry, or go overseas and learn something that will enrich the department where you want to be employed. So I know that sounds very high level, but those are the things which are really critical for success these days. So pretty much I ran a couple of trials. I wrote a trial, my first ever investigator-initiated trial, and from that money, I think the company gave me $250,000 to write it, to run it. I think I only needed about $100,000 to run it. So I had $150,000 to hire a research assistant. With the research assistant, that research assistant set up a few experiments. That gave me preliminary data to write the next grant, and the next one, and the next one, and the next one. So it all starts from one research assistant that you can hire, that works for you, that can do the experiments that you need and want to further whatever your research interests are. What is the most critical thing as a clinician to do research? A tissue bank. If you can have a tissue bank that can provide you tissue samples, real patient samples of the disease you're studying, then this will give you an edge over all the mouse biologists. Because whatever you discover is unarguably real. They can knock out 50 genes in a mouse. It may or may not be real, but anything in a human is real. I started a national registry because Australia didn't have one, and this catalogues all the patients with leukemia and their outcomes. And this is now critically relevant because drug companies, as I mentioned, are all going to come to Australia in the next 5 years with all their new drugs. How many patients with IDH mutation are there in this country? No one knew, but now there's a registry where all that information is collected. So they need this information to get their drugs approved in the country. National trials, as I mentioned, through the National Cooperative Group. I started a molecular laboratory at the Alfred because we didn't have one, and everything in AML and blood cancers is molecularly based. So every hospital needs a molecular laboratory. And then after that, I set up preclinical models, so patient-derived xenografts to test novel drugs. And what's going to be the technique of the future? Single-cell sequencing. If you can get into a PhD and learn single-cell sequencing and take that into the clinic in 10 years' time, you will change the way we practice. Because although sequencing is interesting, that's sequencing of 1 million cells at once and just averaging everything into one readout. But there's not one cell there, there's millions of cells. So if we have single cell data and increase the resolution of clonal heterogeneity down to the single cell level, that's the information we'll need to cure any cancer. So single cell techniques will be the diagnostic techniques of the future. They're not at the moment because the techniques are just being developed, but when you guys graduate and start practicing, I'm pretty confident they will. So I will just give you an example. So this is a patient who has at diagnosis a SRSF2 mutation, and we put the patient under selective therapeutic pressure, and you can see at relapse the patient had an SRSF2 mutation with a new FLT3 mutation. They also had SRSF2 linked to a FLT3 point mutation, and here I can't even fit the words in because the clones are so small. There was a FLT3 tyrosine kinase domain mutation, an SRSF2 with a RAS mutation, a single RAS mutation affecting amino acid 12, and another one affecting amino acid 61. And these are the drugs we have available, and the crosses represent where the drugs won't be effective. So this drug is not effective when you have that mutation, gilteritinib is not effective when you have RAS mutations, and quizartinib is not effective when you have a D835 mutation. So basically, this patient's untreatable, but only because we had the single cell genomic information available. So this is a sort of information you guys are going to have to process in the future, because you'll have all these drugs, you potentially have single cell data, and you're going to have to work out how am I going to treat this patient. So just as a last slide, this is the trial I'm working on at the moment, and it's just recognition that there's clonal evolution, that we have MRD technologies to quantitatively measure at the 1 in a 1 million cell sensitivity. We have drugs that can target FLT3 mutations, but invariably the patient will progress with a different clone. And at the moment we don't have trials to test that, because we have, our questions are very linear. We've got this disease, we're going to randomize between this drug and that drug, and we're going to look at survival. That's not how cancers work. they adapt, but our trials are not adaptive. So this is what's called a platform trial, where if the patient is treated with this regimen for FLT3, let's say they relapsed clonally with an IDH2 mutation, the patient is recycled into this arm, they receive that regimen. If the FLT3 mutation comes back, they can recycle back into that regimen, or if they progress with some other clone, they will get another clone-directed therapy. So the patient will just move between different treatment domains, and the whole aim is to molecularly monitor their disease and treat it at the clonal level before they've got blasts and they're really sick. And so rather than having one linear trial, this is now what's called a recursive treatment approach. So the treatment adapts as the leukemia adapts. Now this is very much at the frontiers of clinical trial development at the moment. But when you guys start practicing, I suspect this is how you'll be doing general hematology, not just in leukemia, but in every disease. This is our national clinical trial at the moment, or trial program. So you can see here, there's a trial for patients with FLT3 mutations and IDH, IDH2. But you can see they're just linear. So what happens when the patient finishes this trial? Where do they go when they've actually got another mutation? So this is what we're trying to replace, because that's how we do trials at the moment. So I'll stop there, and I didn't go into a lot of detail about the specifics of every specific blood cancer, because you're not going to retain that, and you will learn that as a matter of course anyway. And I just wanted to give you a flavour as to, I guess, what translational research is about, and happy to answer or address any questions.
Thanks so much, Andrew, for that very insightful talk. We have some time for questions, if anyone has. I have one question myself. So obviously there are many, many different types of hematological malignancies, like chronic lymphocytic leukemia, mantle cell lymphoma, et cetera, et cetera. Why did you choose to focus on acute myelogenous leukemia?
So the reason was when you graduate and you're sort of working, what most people do is they follow people who are really successful. So when I was starting out, imatinib was just coming out, and so everyone wanted to do CML. But the thing is, when you're the first year sort of registrar or the first year consultant, and someone's already been doing CML for the last 10 years and they're the global expert, my advice is that's probably not the area that you want to go into, because you're always going to be underneath the person that's already established. So I went into AML because at that stage there were no drugs. No one was interested in AML, and there was no one really leading that area in the country. And so furthermore, AML I recognized was really common on the wards when I worked there. A lot of people had AML, a lot of people were dying. There's no new drugs, just the 2 chemotherapy drugs, which I mentioned. But what you have to do, it's a bit like, investing for the future. Do you buy Apple shares when they're at their peak because they're really valuable? Everyone wants Apple shares. Or do you go into a startup where there's unlimited potential? So, but you need to be able to go somewhere where you've got enough patients, where you can set up a tissue bank, do the research and set up the trials. So what I suggest is, when you get through, survey the landscape in your specialty, or whatever you decide to do, see where there's unmet need and go where the unmet need is, because then your job is to meet that unmet need, not just follow other people that have already led the path, but where you're never going to replace them. Yeah.
Any other questions? Sorry, I just have one more question, actually. So relative to other blood cancers, where are we at with acute AML? So what I mean by that is, like, are we at a stage where we can foresee a cure to AML in the next 10 years? or are we far from that?
Many cancers, blood cancers at the moment, are sort of moving into this phase where 3 years ago we never envisaged that they were treatable, to now where any year a drug could be discovered which could completely transform the disease. So for instance, 5 or 6 years ago, ALL, relapse ALL, just was absolutely a harbinger of death. If you had relapsed acute lymphoblastic leukemia, chemotherapy, 3-month median survival. Then along came blinatumomab, which is a drug which links a CD3 cell to a CD19 B cell leukemia. And basically, it sounds crazy, but it's an antibody which just plasters a T effector cell onto the B cell, and the T cell is designed to kill it. It's a blunt instrument, but it's incredibly effective and incredibly non-toxic. And so then all people then did was take that bispecific vector and then just clone it into the patient's own T cells, such that instead of giving the drug, which we have to give as a continuous infusion, the T cell just divides because it's stimulated by the B cell antigen, which is a leukemia, and you just put these CAR T cells into patients and they just grow. And they grow and they've got these CD3 and CD9 anchors on them. They plaster T cells, other T cells onto leukemia. And that's the magic of CAR T cell therapy. And people describe this as a living therapeutic because it's sitting in your body. When there's B cells there, it's stimulated to grow, as T cells are. When the leukemia goes away, then it just goes back into its dormant phase. When it comes back again, it just grows again. Very cool. Now there's a lot more hype to CAR T cells, which you've probably heard about, than reality. The reality is that probably only about 1/3 of people get long-term cures as adults, which is probably similar to the bispecific things. But the people that make and use CAR T cells like to tell the more optimistic version of the story. But it is a phenomenal therapeutic. In AML, again, I would have thought that relapse refractory disease was just, we were never going to crack that. But just last year, venetoclax, which I knew was interesting, combined with an IDH2 inhibitor, so 2 targeted drugs, relapse refractory AML, only 13 cases, but 75% remission rate in 1 month. Now, I never thought I would ever see that kind of thing happening, but that's pretty much the basis of the last trial I've developed. So it's basically venetoclax combined with a targeted therapy against whatever the mutations are, and recycling the patients between novel targeted therapies without the need for chemotherapy. And so if we can get a 75% remission every time and avoid chemotherapy, avoid transplant, and do it for 5 years, then we've made progress, not with one drug, but with a series of drugs adapted to as the disease adapts. So maybe, I don't know.
Any final questions? Would you please join me in thanking Dr. Andrew Wei for his talk. So with the, small token of appreciation. Thank you so much. So thanks guys for coming along today. So we have, as part of the Australian Student Society of Haematology, one final seminar for this year. It's most likely going to be held in the week of the 23rd of September, and it's going to be a seminar on blood transfusions. So if you've enjoyed and found our previous seminars valuable, I'll encourage you all to jump on that. Thanks, guys.